The information shared on the Sky Women's Health podcast is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding your medical condition. Never disregard professional medical advice or delay in seeking it because of something you heard on this podcast. Reliance on any information provided by Sky Women's Health, Dr. Carolyn Moyers, or any guests featured on the podcast is solely at your own risk. You're listening to Sky Women's Health Podcast, your evidence-based resource for women's health and wellness, exploring the holistic principles of osteopathy, integrating mind, body, and spirit, designed to empower you as your own healthcare advocate and help you live your best life. I'm your host, board-certified OBGYN, Dr. Carolyn Moyers. Welcome to Sky Women's Health Podcast. I'm so excited that you're here with me today. We are going to dive into what it really takes to support metabolic health in perimenopause and menopause, including the role of GLP-1s, muscle preservation, and personalized strategies that go far beyond weight loss. And this is a really important conversation for us to have because it is every day, and I too have felt it, that the things that had been working in the past are no longer working, and we're bothered by stubborn weight gain, insulin resistance, cholesterol's rising, elevated blood pressure. I mean, you name it, like things are going south and we're wondering why. But the weight loss is one of those things that just gets every woman in perimenopause and menopause. They're so frustrated. So I have a special guest with us today, Dr. Mona Sodhi, who is an internal medicine physician and is board certified in obesity medicine. She's the founder of Monarch Weight Loss and Wellness and takes a really personalized approach. So I'm so excited for you to meet her. Welcome, Dr. Sodhi.
Thanks for having me, Dr. Moyers. It's my pleasure to be here and talk to your listeners.
Yes, thank you. I think that having your expertise is going to resonate with so many of us. So let's talk about why it's so important to move away from the just eat less and move more narrative that we all told our patients. And then here comes perimenopause and nothing works.
That's a great point. I think that is something that we were taught even in our medical training because we didn't have a better answer for it. It was, move more to burn calories and eat less to consume fewer calories, and it was a simple math equation. Well, now we've come to learn that obesity is actually regulated by our hormones, and it's not quite as simple as move more and eat less. Otherwise, everyone walking 10 miles a day or whatever they're trying to get you to do and eating a salad would lose weight. But that's not the case, especially when it comes to women in that perimenopausal area, whereas maybe they were walking and eating salads before and supporting their bodies and it's no longer working. So it's not quite a simple equation as calories in and calories out. And I think that helps to reduce the stigma that people with obesity have been fighting for many years, which is that it's their fault, that this is a matter of willpower. This is something that is a hormonal issue. And we're also set up to fail in an environment of things like ultra processed foods. So I think it's really important that we understand the disease of obesity, the chronicity, meaning how long, this is a disease that will last a long time. It's not something you can easily reverse. And so it's just important that we give the disease the respect that it deserves, just like we give heart disease that and diabetes and other conditions.
Right. So it's more of a metabolic condition than a moral failing.
Exactly. Yeah.
So let's talk about how COVID changed the public's conversation around obesity and GLP-1s, because it seems like that this is where it kind of made a boost and everyone's talking about it and everybody wants to be on the skinny shot.
Yeah, definitely. I think COVID, as tragic as that was in our lifetime, it did bring obesity to the forefront and recognize that obesity was an independent risk factor for mortality when it came to COVID. And so people started realizing how important it was to have their weight under reasonable control for mortality, meaning less risk of death, less
Sure.
inflammation, and better quality of life. And so it allowed us to really examine it allowed us to examine obesity as a disease and not, as you said, a moral failure. It's much more than that. So people were paying more attention to their body composition, their muscle mass, things that they had never really looked at before. Because prior to COVID, I would say obesity was more of something that had to do with vanity. It wasn't as important when it came to our health. And I think what COVID did for us is it helped us think of it as an important factor when it comes to our health and how interrelated it is with other conditions.
Yes, it certainly is. And I love that you brought up body composition because that's something that I've incorporated into my practice. We have an in body scan. We're looking at body composition. If we're starting weight loss medication, we're looking at that change. Like I might have lost 7 pounds, but I also lost 2.5 pounds of muscle. How do I maintain that muscle mass during my weight loss journey so that that body composition actually shifts and we start to see less percent body fat, less visceral fat?
Yeah, I love that. I have one too in my office, and I can't tell you how much I'm in love with it compared to the regular scale, which doesn't give you any breakdown of your muscle, fat, visceral fat, and it gives you way more data than you probably need to use, but that's okay. But I just love it because traditionally, especially women, have used the scale at home. The bathroom scale is the traditional metric of how you're doing from a weight standpoint, and it's just not enough. And so,
Yeah.
especially when it comes to perimenopause, we do want to be tracking our visceral fat to make sure that it's not increasing because that correlates to increased cardiovascular risk. And now we know more and more about that. So, yeah, I love that the body composition is something that I introduce a lot of my patients to, and they're loving it too.
Can we walk through what's happening metabolically during that menopause transition?
Yeah, definitely. So during the perimenopause phase, the most prominent thing that's happening metabolically is estrogen is going lower than it was previously, which translates to increased fat storage and a different way that your fat is distributed. Um, the thing that you should know is that it tends to distribute more into the abdominal area, which is called visceral fat.
Oh,
That's
we
the
all
fat
know it.
that's that's the harmful
Everyone's
fat,
like,
right?
"Where'd this tire come
Yeah,
from?"
yes, yes. And from a vanity standpoint, I agree. It's not pleasant for us to go through that, but from a cardiovascular risk standpoint, it's something that we don't want. So that's why they talk about how women that actually have the pear shape are considered more metabolically healthy than someone that has an apple shape, where more of their fat is kind of centrally located. And so estrogen plays a role in that. It plays a role because you can't maintain your muscle mass as you would prior to having when you had more estrogen. And so now you're seeing a decline in muscle mass, even if you change nothing, even if you're still doing the same workouts, you're still eating the same way, your muscle will drop off if you're not really intentional about maintaining and building it. So I always tell my patients, let's go into menopause over muscled if we can, so that we can afford to lose some, right? And I'm not talking bodybuilding, I'm just saying over muscled. Let's step it up from where you are now while you've got the estrogen in you, and then when we approach that perimenopause period, it's that much easier to maintain it. And then insulin resistance is also another part of that trifecta that happens during menopause and a decline in metabolic health. So insulin resistance is basically your body saying, hey, this insulin that's supposed to bring down my blood sugar, hey, and it's just not going to be as great for you anymore. And so what happens is it's a vicious cycle where your body has to make more insulin to do the same job that it did before. And insulin is anabolic, so it makes you gain weight. So it's just this kind of vicious cycle that you enter. So it's really important, circling back to muscle, to maintain that because that can also help prevent that insulin resistance.
I love that you bring this up because so often women say, "I haven't changed anything, but I'm gaining
Yeah.
weight." Right?
Yep.
And it's the
Yep.
metabolic changes that are happening that's leading to this. And there's a 0.6% loss in muscle mass annually as we go through that menopause transition. So, to your point, being very intentional about building muscle, what does that look like for you and your patients? Because I know that you do a very tailored approach. So, talk to us a little bit about your clinical approach with weight as a metabolic condition.
Definitely. So, especially for patients that are on a GLP medication, but for anyone that wants to lose weight, I do talk about how if we do nothing and we're not intentional, you will lose fat and you will lose muscle. But if we are intentional, meaning strength training and protein intake focus, we will preserve from some of that muscle mass and maybe even gain some muscle mass if we're really intentional. So, it's setting people up for success by having that conversation and expectation management upfront, saying, hey, whether your weight loss plan includes a GLP medication or not, we've got to be intentional about muscle because that's what we want to preserve. And even if muscle, let's say you don't gain, you don't lose weight in the first month or two, but you gain muscle and you lose body fat, that's still a win. So having that discussion about what are the metrics that we're following when we're on our weight loss journey is really important.
Yes, I agree. So, in regards to that, how do you counsel patients or what are your recommendations for weight training and for protein intake?
Yeah, good question. The answer is it depends. It depends on where the person is starting. So I'll never push someone beyond their limit and what they're capable of today. I'll say, what do you
Right, start
normally
where you
do?
are. Yeah.
Yes, what do you normally do? And let's say someone's having 20 grams of protein 3 times a day. Great. Encourage them and say, keep doing that. And let's see where we can squeeze in a little bit more. So maybe that looks like adding in a strategic snack or maybe that looks like increasing the meal protein at breakfast or dinner or whatever. So I meet them where they're at. I never prescribe and say you've got to do 30 grams 3 times a day right off the bat. If they're not anywhere near that, they're probably going to get constipated trying to get to that goal. So we gradually increase that. Same thing with strength training. I mean, if someone has never lifted a weight in their life, I'm doing wall squats with them in the office. If they are already, like, I have a couple people that were collegiate athletes and marathon runners, I meet them where they're at and they say, okay, I know you love the high you get when you're running, but I want to see you lifting some weights a couple times a week. It's going to improve your run, but it's also going to improve you metabolically as we work on weight loss. So it's really about meeting them where they're at. But if I can get them strength training 3 times a week, 30 minutes, and rotating the different muscle groups, that's a win.
I agree. Yes. So for people who are starting from scratch, I'm usually like, let's start with body weight. How about
Yes.
some Pilates? Let's do
Yeah. I
twice a
love
week for
Pilates.
20 minutes.
Hmm.
Let's start where we are. I love that
Yeah.
message. Okay.
Right.
So let's get into the science of GLP-1. Everybody acts like it was an overnight success, but these have been prescribed for 20 years or so. Let's talk about exactly what it is, what's the difference between the GLP-1 and the GLP and the GIP, and how do they work?
Yeah, definitely. So GLPs have been around like Ozempic for quite some time and they've been used for diabetes, but then we realized that, hey, these people on this medication are losing weight. And so then they were explored for other indications, including weight loss. And now that's expanded even further into other indications like sleep apnea. But the way that they work is pretty simple. Simple but complicated in the background. So, what you feel is really a reduction in your appetite increased in fullness or satiety and a reduction in cravings. So rather than a lot of people have this food noise where they're consumed with what am I going to eat, where, when, how, pulling over when they're driving on the highway to, because they get a craving for something at the gas station, for example. Um, it helps quiet that food noise and helps people make just better decisions in what they're doing. Okay, so that's the mainstay of what it's doing is just regulating your appetite in a normal fashion. A lot of people will come to me and say, I never knew what it felt like to not have cravings all day long. And so I think that's really, really powerful. They do slow down essentially the GI tract, and that's why sometimes we can talk about the side effects that we see. They can happen where you get constipated, maybe you get some nausea or acid reflux. A lot of that's related to the slowing down of the gut that happens, which makes you feel more full. But that's really it. We know that the GLPs like Wegovy and Ozempic, they work really well, but then these superstar medications like Zepbound and Mounjaro came out. Those are GLP and GIP, so they've just got an additional hormonal component to them, and they do work a little bit better. Those ones we're looking at like 20% weight loss. As opposed to Ozempic, which is more like in the teens. So they're both categories are both great drugs, GLPs and GLP and GIPs. in the pipeline. We've got triple agonists coming in even more. So from everyone I've spoken to in the pharmaceutical industry, it sounds like we've barely scratched the surface of what's possible, which is really exciting.
Well, I think what's so exciting is that before it was, your stimulant drugs or just metformin for the insulin resistance, but not always super effective as sustained weight loss. Whereas people with GLP-1s and the combination medications are seeing sustainable weight loss in long term, like
Yeah.
really meeting their goals.
Yeah, definitely. I think the stimulants, for a lot of people, they've been on amphetamine and whatnot, and they work in a select population. But for most people, the side effects are real. I mean, it's like they just feel like they've got high anxiety, they can't sit still. And then metformin is a great drug, and I still actually use it, but it's not quite as efficacious when it comes to weight loss. And it doesn't have actually the data that the GLPs have when it comes to reduction of cardiovascular risk. So I like metformin as a drug. It's cheap as well, it's generic, but GLPs really take the cake when it comes to efficacy and reduction of risk.
So there's a lot of talk about it being anti-inflammatory as well. Are you
Yeah,
seeing that?
definitely. I mean, when it comes to things like osteoarthritis, I'm seeing patients that they probably still need a knee replacement, but their quality of life is already better because they're on a
Mhm.
GLP and their joints are less inflamed. Seeing some people with rheumatologic disease also responding really nicely to GLPs. Again, not curative, but their symptoms are better. Their quality of life is better. So that's really great. I mean, just in general, I feel like the it's not just the weight bearing on the joints, it's also that reduction in inflammation. So even my runners are just feeling better when they're out there and,
Sure.
pounding the ground with their sneakers. Like it's just an easier experience. So
Yeah.
from an that's then there's more research being done on the inflammation reduction standpoint.
So, is a good candidate, and when do you decide they're appropriate? And, I also prescribe GLPs, but I'm, asking you as somebody who's obesity certified because I wanna
Yeah,
hear what you
yeah.
have to say too.
Yeah, I mean, I think expectations, coming back to that, is huge. So whether someone's BMI body mass index is 27 or 37 or 47, I mean, I still have similar conversations with them saying that, look, if we're going to use this medication, just understand that it's a tool, and we still have to work on the lifestyle pillars: sleep, movement, nutrition, stress management, and if needed, hormonal optimization if they're in that perimenopause phase. So I need someone that's an ideal candidate for the drugs to understand that they're still going to be doing their part in this and letting the GLP be a tool. They, ideally, when it comes to meeting criteria, it would be a BMI of 30 and above, or a BMI of 27 and a comorbid condition, meaning hypertension, hyperlipidemia, sleep apnea, things like that. Those are the criteria that have been drawn out. But again, I will take everyone on a case by case basis. I'll look at their family history. I'll take it their, are they of South Asian descent? What are the risk factors stacked against them before making a decision to whether or not to prescribe a medication to the individual in front of me.
Sure, yes. So very individualized approach. I do the same thing. You said that GLPs are tools, and I completely agree. And as we're thinking about in terms of long-term perimenopause, menopause transition, and needing hormone therapy, I'm not sure if you're familiar with the weight loss response to semaglutide in postmenopausal women article. It's a retrospective study, so not our really gold standard in forms of study, and it's a small study, but it's exciting to see
Yeah,
that
definitely.
women who are on hormone therapy and semaglutide had greater weight loss
Yeah,
than those off,
fantastic.
and it was looking over 12 months, there was a
Yeah,
significant,
yeah.
reduction.
I think that's fantastic, and I would love to see even more data for the next 12, 24, or 36 months to see how these women do and the duration needed for therapy, whether it's, what they call microdosing, a low dose, or, higher dose. That's something that I'm always playing with, even on in my non-menopausal patients. I'm seeing like, what is the dose that this person needs for the next 5 years or 10 years? We still don't have those answers, but it is highly individualized as to what everyone needs.
I'm so glad that you brought up microdosing because that's something that everybody asks about, this microdosing. What are they really talking about with microdosing?
I think it's something on social media that caught wind. I don't know quite what that trend is about, but I know that in my practice, I am microdosing because not everybody needs to be on the highest dose possible of
Right.
Zepbound or Wegovy. It's just, it wouldn't be responsible or safe to prescribe that high of a dose, right? So if someone's doing really well on a low dose, I say keep it going. Like, let's maximize this and get the returns on it that we like as much return on it as we possibly can. I don't see the need to go up higher and higher. I know that the studies did study the highest doses for most of these drugs, and that's why it's recommended that we go up to the highest dose. But for a lot of people, let's say you're starting at a BMI of 27, you probably don't need to be going up to the highest dose, right? And you may
Sure.
be very sensitive to the lowest dose. And I do see that with a lot of people where they've got significant appetite suppression, even if they go up one tier of dosing. So we keep them on that low dose because again, I'm not playing with fire here. These are patients' lives in my hands. And so I need to make sure that I'm doing a responsible thing by them and that I'm not, that I'm not incurring any type of harm to them. So microdosing, I'm open to it. Whatever social media wants to call it is fine. But to me, it's just getting the right dose, just like with a blood pressure medicine. You wouldn't shoot somebody up to the highest dose, right? Not
Right.
everybody needs it. So that's how I see it. How,
Absolutely.
how about in your practice? Have you seen a lot
Yeah,
of
I
people
do
do
the
well?
same. I do the same. At the lowest dose, if they are experiencing that reduction in food noise
Hmm.
and they feel better controlled and they're better able then to focus on their healthy lifestyle habits, I think that that's a
Exactly.
win. So,
Yeah,
yeah. So, what
definitely.
are some myths you're hearing from patients and clinicians alike in regards to GLPs?
That's a great question. Something that I was hearing a few months ago was more about the gut paralysis. And I think, again, the news caught wind of that. Um, I haven't had anyone with severe gastroparesis from a GLP, and that just means severe slowing of the stomach. Yes, it'll be slowed down, but if you're on the right dose, you can still eat a meal. You can still enjoy with friends. You're still having bowel movements. So I think maybe one or two cases caught the media's attention and who knows what the cause, or maybe these people had diabetes that wasn't under control before they started a GLP. But there's this myth that your gut will be paralyzed and that you'll never have a normal bowel movement again and you won't be able to eat regularly ever again. I'm just not seeing that clinically, and I've treated thousands of patients by this point. So that's frustrating to hear, but I do talk to every patient that has a concern about that. The other, I don't know if it's more of a myth or just a concern that patients have, is that they'll get Ozempic face, or that they won't look like themselves. And again, we talk about muscle and we talk about the importance of, whenever possible, I love to see slower weight loss as opposed to rapid weight loss because it gives us that chance to build the muscle and avoid, things like whenever we lose weight rapidly, our gallbladders like to act up, right? So we just have that conversation that not everybody looks like a skeleton that's taking a GLP. Those people that look like a skeleton are very gaunt, maybe just on too high of a dose for them, and it's just not appropriate treatment. And sometimes that can happen if you're getting it from, a place where they're not monitoring you properly.
That's a fair point because everybody's prescribing GLP-1s now. And let's speak to getting the branded medication versus getting it compounded. I want to hear your thoughts on this because a lot of times, like pre-diabetics, I cannot get it covered by their insurance company. Like, we are overweight, we are insulin resistant, yet we don't want to cover this unless they're a diabetic. It's
Yeah.
infuriating.
Yeah, that's a good question, and I think my stance on it has wavered a bit over the years, because I'm traditionally trained physician, and we trust things that are vetted and approved by the various bodies that there are, like the FDA. And my first choice always is to go with something that is FDA approved, because we just know what is in that medication that you're giving to a patient. If due to financial reasons or due to um, lack of availability, which we saw last year, if due to those reasons there is no alternative, then perhaps compounded medications are a suitable fit for patients that are, needing to be on a GLP medication. The reason that I like to go with GLPs that are FDA approved first is just because of the consistency. We know exactly what we're getting in the product. There's no question. Compounding medications can come from various pharmacies and various sources where they get the ingredients for their products from. So they have been called into question when it comes to the purity of the medications that are compounded. It doesn't make them inherently bad. It just means that you need to be looking into the pharmacies and making sure that if you're going to go the compounded route, that you know what the pharmacy is and that your doctor is okay with it. So I think it's just a discussion to be had, and I'm open to it. But again, whenever possible, I'd like to go with something that's vetted, like an FDA
Yeah.
approved medication. How about
Yeah.
you? What are your thoughts?
Same. Same. And, my endocrinologists are really picky about they are not fans of, of compounding. So I try to be
Yeah,
very respectful of that.
yeah,
But yeah, I mean, when we need it and we can't access it in any other form, well, I did just learn about Lilly Direct. So that's
yeah,
exciting. You
exactly.
can get
I
more affordable pricing for
That's a
cash pay
great point.
patients.
Yes. And a lot of my patients are choosing to do that. And I love that Lilly and Novo are bringing their prices down and meeting, I think they're probably comparable to the compounded medication. So price isn't even maybe a battle anymore. That's a great point
Yeah.
that they're doing that. So, I used to be pretty fixated that like FDA approved was the only way to go. And now I'm just more open to the conversation of why is this person wanting it? And is the risk of them taking compounded medication versus living with the disease of obesity? Like what's the risk benefit there? So I do evaluate everyone individually when it comes to that.
Yeah, I would agree. And I vet out compounding pharmacies before I'll consider using them.
Yeah, of course.
What kind of safety measures are they using? Do they have
Yeah.
any?
Yeah.
Um,
The important thing to know with that is that not every I don't like to use this term much, but provider is doing that. Sometimes they don't know what they don't know, and they're just using a pharmacy that they've never had contact with, or they don't understand the process of what goes into making a medication. So it's really important to go with someone that you trust when it comes to prescribing a GLP medication.
I agree completely. Well, I feel like we have hit a lot of the high points that I had on my list to talk about. I want to know what excites you about the future of GLPs and
Yeah.
hormone-based obesity treatments.
Yeah. So, in line with what we've been talking about this whole time, there are some medications in the pipeline that will actually help preserve muscle mass. So when those come out and those are available, I'm here for it. Like I'm ready to see that because that'll help the patients that are struggling to preserve their muscle mass. What also excites me is just that this conversation is even happening. Because again, it wasn't that long ago that having obesity was a stigma and it was a disease of willpower. I love that people are just talking about getting healthy and it's not about looking as thin as possible. I love that people are like, look at how much muscle I have. And they're really, women especially, are taking pride in lifting heavy weights, doing Pilates, and not just all that cardio that was, emphasized to us when we were younger,
Oh my gosh,
right?
it was so emphasized.
Yeah.
Women are doing all the cardio and none of the muscle.
Yes.
I just saw
Yes.
the other day that Kelly Casperson had just left the gym and she was like, I have a problem today. She's in the gym. There's one woman. She's like, where are all the women? I'm like, women are intimidated by the weight room at the gym. Just they're intimidated. Okay, how do you coach your patients through the psychological changes that come with their either rapid weight loss or just the body changes with consistent weight loss?
So, this is something again that we talk about at the onset. We'll talk about what are the current stressors in your life, right? You mentioned COVID before, that was a big stressor. We talk about being mothers, that's another stressor. Being married or, having a job loss. There are all these things that happen in life, and those things are going to keep happening. So, I have conversations with my patients about that because those are going to keep happening. You may look and feel different, but you still need to mentally understand how you process your stress because your stress is related to your health metabolically, cortisol specifically. So, we want to work on stress reduction techniques whenever possible. And that starts day one. It doesn't start after you've lost the weight. The mindset work is key. And you want to feel comfortable in the new body that you're in. You also probably want to understand that people will make comments about your body. And they probably shouldn't be doing that, but they're going to do what they're going to do. And you need to be prepared to say, my intrinsic worth is who I am, not how I look. And I think that's another thing that's important for especially women to have an understanding of.
Yes. Oh, absolutely. We are so judged by our hair and our clothes and our purse and our
All the
makeup and,
things.
like our weight, all of the things, like just constant judgment. And men just show up with their bare face and their bald head.
I never got that. I never got that.
It's just rude.
Yes.
Okay. I was thinking, you mentioned a couple of different labs that I was thinking, I wonder what labs that you would recommend because you brought up insulin. And so some people come in asking for their insulin to be tested. And you also brought up cortisol. And this is one that I rarely catch misbehaving. you know, people
Yeah.
are often like tired and stressed because they're not
Yeah.
sleeping and they're having hot
Yeah.
flashes and night sweats.
Yeah.
And
Yeah. Yep. Totally. Cortisol specifically is not something that I measure because of the timing of it. I don't always, I won't be checking that specifically. Insulin, yes, because that gives you a good idea of is this person insulin resistant or not. Along the same lines, the hemoglobin A1C to see if someone has prediabetes or diabetes right off the bat. TSH, to screen for any kind of thyroid dysfunction that they might be having. And a high sensitivity CRP can be helpful when it comes to inflammation. So that's something that I will check if someone's interested because it can correlate with their cardiovascular risk. Again, it's not specific, it's pretty sensitive, but it is just one data point to measure. And it's especially nice when you can see all of these parameters improve during their weight loss journey. Of course, you can get into lipid testing as well to see, what their risks are when it comes to that. Those are the basics when it comes to screening someone at the onset of their weight loss journey.
perfect. Okay, I love that we went through that because that's a common question, and very much in line. I think I'm going to add the insulin and the CRP. Those are ones that I have not been consistently doing.
Okay, awesome. What is there anything that you do that maybe I could learn from? Or are you more focused on hormone health and that kind of thing?
So I take a holistic approach. So I'm looking at the whole person, and I do look at their cardiometabolic health, any
Mm,
underlying factors,
yeah,
because so often in perimenopause, it could be a thyroid disorder, insulin resistance, or
yeah.
vitamin D deficiency
Right. Oh, that's
masquerading,
another
right?
good one. Yeah, that's
As
another good one. Yep.
perimenopause.
Mm-hmm.
Yeah.
Mm-hmm.
So I do a comprehensive lab panel before
Yep.
we
Yep.
get started. And I like doing a
Yep.
thyroid panel. I don't do, a TSH with reflux. I want to see the
Yeah.
whole thing.
The whole
How
thing.
are we
Yeah, no,
functioning?
that's all important to take into
Yeah.
account, definitely.
And also
Yeah.
I look at their kidney and liver function. So I get a CMP to make
Right, right.
sure.
I forgot
Yeah.
to mention that. Yep.
Yeah.
Definitely wanted screened for things like fatty liver, because the nice thing about that is you can reverse it. So with weight loss.
Yeah.
So I'd
Yeah.
like to check that
Absolutely.
as well.
All right, let's do some recap on our key takeaways. I think weight isn't the whole story. So just stepping on the scale and seeing pounds is not the whole story. I often tell people when they get on the InBody scan, whether you're 132 or 232, we all have feelings about that, right?
Yeah.
You plug in your
Yeah.
height
Yep.
and you get a BMI, but what does that actually tell you? So we learned today that muscle matters. We got to eat our protein and lift our weights to make that
Mm-hmm.
happen because we're going to have an inevitable loss in muscle mass if we're not intentional. And then personalized evidence-based care does exist for those weight loss, whether your BMI is 27 or 37 and you're wanting to lose that weight. Having somebody who can help you work through that is really key. So make sure that you're vetting your source, you're vetting your doctor, your provider that you're choosing to see, to make sure that they have a good understanding of that. Dr. Sodhi, tell my listeners how they can connect with you.
Sure. So I have a website for patients that are in Arizona and Pennsylvania, monarchconciergewellness.com, or they can find me on Instagram at Dr. Mona Sodhi. And if they're interested, they can schedule a discovery call with me and we can see if it would be a good fit to work together.
Oh, fantastic. I love that you do the discovery call. And so I didn't realize that you were licensed in 2 states either, so that's beneficial too. Fantastic.
Yeah,
And
definitely.
your ideal client is somebody who's 40 and older, kind of working on their weight loss journey, is that right?
That's who I tend to attract. I do have some patients that are younger, but yeah, definitely more women tend to come to my practice in their 40s.
All right. Well, I invite you to share this episode with a friend who's navigating weight loss during perimenopause and menopause. And if you found this episode helpful, I would love it if you leave us a review to help other women find good evidence based information so they can be their best healthcare advocate. Until next week, be well.